Williamson. I'm talking about the 2025 Assisted Living Community National Patient Safety Goals. The topic I chose was Identify Residents Correctly. It's under Nursing 010101. So, my why, the reason why I picked this. I have a serious passion towards this. I worked in assisted living for many years. Sometimes identifying patients wrong can lead to serious complications. It's really easy to mix up those old ladies with the same hairstyle. It can lead to HIPAA violations because sometimes things get overshared. It's 100% preventable. And then nothing is worse than causing harm to someone you care about. When we're taking care of these residents, we tend to love them like we do our grandparents, and so we obviously don't want to do any harm to cause that. And then this is just something that should never happen. So my experience that I would like to share is called Shirley or Jackie. Who is who? I had an experience where I was coming onto a shift and a new med tech was coming off his shift. As we were giving a report, I learned he had made a really bad medical error, and not just a wrong time, but the right patient. It was a much graver error than that. He had given Jackie all of Shirley's morning meds. I know these two women and had no idea how that could possibly happen. As he explained though, I could easily see how that mistake happened. He had gone to Shirley's room to give her her meds, but she was not in there, and he was told that she was getting her hair done at the salon. However, he didn't realize that Jackie from another hall was also getting her hair done in the salon, and that Shirley had actually just left for an appointment, or had left the facility with her family after her hair appointment. So when he walked in, it was just Jackie, and she was underneath the big hair dryer, and she's practically blind, and so she couldn't really see the meds that he was giving her. But he said, "Hey Shirley, I have your meds." But because of the noise and the blindness, she didn't really understand that he said Shirley, not Jackie. Within less than 30 minutes, Jackie was so sick with nausea and vomiting, low blood pressure. Her vital signs were really low. So like her blood pressure, her heart rate, they were all just kind of dropping. She looked really pale. Excuse me. It was quickly discovered upon Shirley's return to the facility that Jackie had actually been given her meds. Jackie's family rushed her to the emergency room, and thankfully she was okay, but had been given meds that were contraindicated with her other meds that she normally takes, and then just some comorbidities that she has. This new med tech had worked at our facility for about 4 months, but he had worked as a knock shift aide, and so he had never really interacted with these women before, and so he didn't really know maybe finer details about their appearance. So when I asked, like, how did you mix these women up? His response was, well, they both have the poof grandma hairstyle. How was I supposed to know? But had he used 2 identifications, this mistake would have been avoided if he would have used like date of birth and name and gotten rid of any distractions. So improving medication safety is 1, prevention. A licensed pharmacist reviews each resident's drug regimen and monthly medical record every month. There is a due process of prescribing, ordering, delivery, storage, preparation, administration, and monitoring of meds at facilities. The next one is using the EMR. The EMR provides electronic medical records that are automatically marked off when medication is given. Using the EMR correctly improves safety of delivery, tracking allergies, and monitoring of residents' responses to the meds that they take. And then also adhering to the 5 rights: the right patient, the right time, right frequency of administration, dose, route, and the right drug. The evidence-based rationale that I have is medical errors result in at least 1 death each day in the United States. These are preventable mistakes. An MAE is a deviation from the prescriber's medication order as written on the patient's chart, manufacturer's preparation, administration instructions, or relevant institutional policies. These are basically medical errors that nurses make by not adhering to the patient medication rights. As nurses, though, we know there is more than the rights of the patients that can cause medication errors. Overstaffing, interruptions, distractions, burnout, etc. These are also considered real and viable players in the medication errors that occur in the United States. And then for my references, I did a National Academies of Science, Engineering, and Medicine article, and then I also did another article in the Joint Commission Journal talking about nurses' perceived causes of medication administration errors. And that's it. Thanks.